right, thanks everybody. It's wonderful to be here, and I think, Dr. Siegel, what an amazing talk. You should give that at every conference around the world on this subject. It's an amazing primer and gives the context. And a lot of the points that I think will come up during my talk will resonate with some of what was raised. And then I also think that the panel discussion will be a really interesting, rich conversation about just exactly what is it that right now is very much hype versus what is reality, what can we expect to actually happen versus what are people hoping will happen. And so I'm so pleased to be here, and I am delighted to be at a place where wearing this suit doesn't make me feel out of place. You guys will notice that I come from a place where business attire means breaking out your best hoodie or your t-shirt, or at least the one that doesn't have a hole in it. So usually in meetings, I'm the only one dressed like this. Other folks are dressed differently, and here I feel at home. So thank you for having me. So I have no financial interest in any of this stuff or any of the technology that I'm going to talk about or the study here. You know, the one disclosure is I'm a clinician by trade, and I do this full time. I can talk through the technical stuff. I've been forced to learn it through these projects and through some of the other things that I've worked on, but my knowledge ends at a certain cliff, and beyond that, I can't really speak facile about that. And so my approach and perspective is going to be primarily from a clinical perspective. And I've got one last disclosure, but this one I need to keep between all of us in the room here is I have a superpower. I don't know how many of you guys have a superpower, but my superpower is, it's okay. It's a medium superpower. It's not like flying or like throwing webs or anything like that. So what I can do makes me pretty popular at cocktail parties. So I can make a diagnosis just with a single glance. I can spot a skin cancer from across the room. That's kind of cool, right? I don't think you guys would believe the number of people who at a party, they see me, they find out what I do, and they're pulling up their shirts, they're taking off their shoes, right? They're pulling down their waistbands. And then audaciously, I've had few examples of people who said, hey, come with me to the bathroom, there's something I want to show you. That's where I draw the line. But the social faux pas, they actually go both ways. So if we happen to be talking later at some point and having a discussion, and I'm looking at your neck instead of your eyes, it's because I'm spotting something that I'm finding suspicious. So I apologize in advance if I do that. It's a power that just, you can't turn it on and off, it's always on. And sometimes it's helpful in the clinic, sometimes when you're on the subway, you get some dirty looks. So all kidding aside, this is a really kind of cool thing that I'm able to do, and there are not that many people who do that. There are like 10,000 board-certified dermatologists across the country. But what if we could take that ability and that superpower and really make it something that anybody could wield? And what if all it took to wield that superpower, as I see all of yours on the phone, on the tables, is having one of these? So what if instead of 10,000 people, anybody with one of these could do the same thing that I could do? That's pretty powerful, potentially, right? So what are the things we could do with that? Well, melanoma is a sucky cancer to have. It's really sucky when you catch it late. It's kind of okay when you catch it early. There are things that you can do, and the survival curves very, very much split out. And so what if we could catch melanoma at earlier stages? I see patients all the time who come in, and their melanomas are at a late stage. And if only they had been spotted or diagnosed earlier, there's a huge survival advantage and difference. If you had the ability to have this on your phone, and everybody did, could we shift these curves? Could we have melanoma diagnosed in stages where it could be cured, ideally, or at least treated in a more successful fashion? Access is a huge issue, right? So could you essentially deliver high-quality, low-cost care, diagnostics across the world? And let's not even talk globally, right? We don't have to look much further than our own backyard to find access issues, inequality issues. Did you guys know that it takes 32 days on average for someone with a suspicious mole to get in to see a dermatologist? That's the national average. In cities, it's much worse. In Philadelphia, it's 78 days. Chicago, I don't have data for, but Minnesota, I think it's about 40 days. Boston, it's 52 days. If unfortunately you have an HMO, it takes you 30 days to get in to see your primary care physician, and then another 30 or 40 days to get in to see your dermatologist. That's an access problem if I ever heard one, right? So could we make a dent in accessibility to essentially high-quality, low-cost diagnostics? I think we can. And certainly so did my colleague. My colleague and I had started this email chain a couple years back, or more than a couple years back now. And I captured this for posterity, but he said this was around the time when that relatively well-known now paper came out showing that AI could differentiate between breeds of dogs. And he said if AI can differentiate between breeds of dogs, what we do in dermatology, there's some parallels there. What could we do in dermatology? And so that sparked the genesis of a team effort that centered around this vision of how do we impact the clinical field of dermatology using machine learning techniques, right? Okay, so like any such effort, you've got to start with data. You got to start with some good data, and you got to start with a lot of data, right? So we constructed a data set. We gathered images that were clinician labeled, many biopsy proven. We looked through online data repositories, and we augmented that with a lot of clinical images from our own Stanford dermatology practice. And we ended up with 130,000 images across the breadth of dermatologic disease. So there's like 2,000 dermatology diseases. So really a wealth of information and well clinically annotated, many biopsy proven. Just to give you a sense, at the time that we did it, this was a twofold order of magnitude larger than any previous effort. So we started with a pretty good built-in advantage. And so what we did after we had this data was we created this tree-structured, sorry, am I echoing? We created this tree-structured taxonomy where we essentially took these individual diseases and then we continued to group them into larger categories until we got to essentially we completed the tree. So what you'll notice, this is a partial visualization of our taxonomy. And you can see the three main nodes here branching out from skin disease, right? The world of skin disease. We have benign skin lesions. These are these cellular proliferations that don't do any harm. And then we have malignant lesions. These are your melanomas, your basal cell skin cancers, squamous cell skin cancers, and then all your weird and wacky cancers. And then you have this inflammatory, infectious category. This is stuff that encapsulates stuff like psoriasis, eczema, impetigo, acne, some of your common things that we see. Okay, these are just some examples of malignant images, collages. So I like to build collages. Dr. Bam likes to make videos. So this is my collage of malignant images. Okay, benign images. Just to give you a flavor of some of the things that we had in our data set here. Okay. Then we trained, right? So we trained our data set. And let me show you how it works. So our goal in the training was to have one system, not a piecemeal system, but one system that could essentially deal with any of the variations in things like lighting, zoom, angle, color, all these variables inherent within clinical photography. So you didn't have to do any pre-processing, right? You didn't have to have a clinician go and sort of carve out where the lesion was and do all that work before it actually spit out a classification. Take any photo of any skin lesion, feed it into the system, and get a classification. So I'll show you a diagram of sort of how this works. So skin lesion image, this is a melanoma. If you have one of these, come see me afterwards, please. We use the Google Inception V3 convoluted neural network system. And it was pre-trained on the ImageNet database, which is this huge database of 1.3 million images or so. And then we trained it and fine-tuned it on our data set of about 138,000 images. So this picture will go through and it does this black box stuff. And then it'll spit out sort of probabilities across the various classifications, and then depending on what task you want it to do, so these inference classes here, it's essentially malignant or benign, it just sums up the probabilities of all the classes nested underneath of it. So this is sort of the output that you would get if you were asking the system to say whether something like this was benign or malignant. And in this case, it says, hey, we think it's most likely malignant, and it's correct. Okay. So after we did all that, after we built this, after we trained this, we were ready for the big show, right? We're ready to evaluate it. And we wanted to test essentially our system on some clinically relevant tasks, right? There's a lot of things that we could do. We had this really cool system. You could do lots of things, right? You could do, is this an STD or not? You could do, is this a fungal infection or is this psoriasis? We chose skin cancer because one, cancer is, I feel like, an important thing. And also, to be honest, it is something that helps. It's sort of a sort of foot in the door, right? So all of those things I think will be as important and helpful. But the skin cancer stuff was certainly the one that we wanted to do first. And so the three tasks that we asked it to do, one was distinguishing what we call keratinocyte carcinomas. So these are basal cell skin cancers and squamous cell skin cancers. We wanted to differentiate that from other epidermal proliferations. These things are like warts or seborrhea keratoses, these wisdom spots for those of you who are blessed to have some wisdom in your skin. And then the second task is distinguishing melanoma from safe moles. And then the third task is a variation of the second task, essentially distinguishing melanoma from the safe moles using something called dermoscopic images. These are just images taken with this light microscope thing that we sometimes use in the clinic. It's a handheld device. Okay. So just to give you an example and show you what we were dealing with and what kind of images they were, here's just some sample test images. And I'm going to tell you that half of these are malignant and half of these are benign. The top half is either malignant or benign. The bottom half is either malignant or benign. You guys think you could figure out what is what? Who thinks the top half are the cancerous things? Some people. Who thinks the bottom half are cancerous things? Who thinks this is a trick question? It's kind of hard, right? It's not a trivial, easy thing. And I wanted to show you these images to give you some perspective of what the humans and the neural network were up against when they were doing this task. Okay, so these were the results for the neural network. And when we did the testing set, we made sure we scrubbed it. It was not part of the training set. All of them were biopsy proven. These were really robust test sets. And so this was the performance of the neural network across these three test sets. And what you'll see here is receiver operating characteristic curves. And these are just built by varying the threshold, essentially, to get sensitivity specificity curves. And the area under the curve is a good proxy for the performance of the neural network. And you can see it performed pretty darn well. So the areas under the curve for these three tasks range from 0.96 to 0.94. This is interesting, but I think more relevant and for us, what we really wanted to do is, okay, how does this then perform against the best humans, right? Okay, so we recruited 25 of our colleagues across academic medical centers, all board certified dermatologists, people who have been doing this for a long time and doing it really well. And we gave them a test as well. So each of these red dots represents a dermatologist. You'll see that we started with 25 and then people got tired and they got frustrated and they dropped out. So the last test, we only had 21 people complete it. But what you'll see is the green dot is the average dermatologist and then the error bars are one standard deviation. The neural network outperformed the average dermatologist on all the tasks. There are some outlier, dermatologists who did better than the neural network, but all in all, everything said and done for this very specific task, the neural network outperformed the average dermatologist. So let's do the fine print thing first, okay? So the fine print is this is a very contrived artificial task. This is something that was built on images that were not mostly from real live clinical patients and things that you would see in clinic. These are textbook things. So we can't extrapolate this to what would happen in real life clinic, right? There's a lot of things that would be necessary before we looked at this prospectively in a validated setting across the whole spectrum of skin diseases that we see in the clinic. So please don't take this as this is as good as what clinicians can do in the clinic. Okay, so that fine print aside, when I saw this, I was absolutely blown away. This is astounding. A neural network that we trained in a matter of weeks on this task, which is pretty core to what we do as dermatologists, it outperformed actually most dermatologists, people who have been doing this for decades, right? That's pretty humbling. And this is just that first point on the curve of improvement. This is just a starting point. It's not the peak of what it can do. It only gets better from here. So that's I would say that is a pretty cool result. And so we wanted to share this, and we're fortunate to have this published in Nature, I think partially because it was sort of a good story. But I was actually more tickled by Dr. Topol, who I consider sort of the father of patient-centered, consumer-driven care, giving us a shout out. But I think what happens is then the hype kind of takes over a little bit, right? You get something like this, and then what people say is they don't look at the fine print. They don't look at that. What they say is, okay, machines are as good as dermatologists at detecting skin cancer. So that's kind of not true. So let's talk a little bit about that. So we got a lot of great emails. Dermatology is a pretty small community. We got some less great emails, some outright nasty emails as well. Some of the people who are colleagues and friends, they would say, hey, you know, what did you guys do? Are you gonna come for my job? Wink, wink, right? But kind of not wink, wink, kind of a little concerned. And then there were people who said, what did you guys do? You're gonna destroy our specialty, right? We're gonna go the way of pathologists and radiologists. That's not true, right? We heard a lot of reasons why that's not true. I completely agree. And so this is kind of the flip side of whenever we have something like what AI is essentially now, all the hype around it, there's a lot of misconceptions, even around the people who do this for a living, right? The clinicians, they get wrapped up in it as well. And it's really some of the nuances that are important, but that are also kind of difficult to have a one sentence or two sentence conversation about to highlight. So I want to talk about maybe a couple of those things in the time that I have left, why sort of this nuance matters. So one is what we did with that task that showed that the machine was as good as the dermatologist is we kind of tied one hand behind the back for our clinicians. That is a completely unnatural thing for a clinician to do, is to take a look at one lesion and to say, okay, you got to make your decision. Because in the clinical setting, that's not what we do, right? We do so much more. So even just by looking at a patient first, I look at them and then I look at the lesion. That gives me really rich information. I can see, what skin type they are. I can probably see how much sun damage they've had over the course of their life. I can see sort of what their skin looks like on their face, and then I can take that into account when I look at that spot on their body. Context really does matter. I think what we miss when we look at individual single lesions is what is that lesion in the context of everything else that's going on about that person and on that person's skin, right? We miss the things like risk factor. We also miss what do the rest of their moles look like, right? If all of their moles look like that and the machine is saying it's a melanoma, well, that's probably not right, because you take that mole and you put it on someone else, it might be a melanoma, but on them, that might be their mole pattern. So there's this concept that matters a lot. And that makes things really complex if we want to try to teach a machine to do that. One, you start to run out of data, right? It just doesn't exist. People don't take full body photography, and we don't have decades of experience of what happens to each of those individual lesions. So that's going to be, I think, an inhibiting factor. And then it's also a really difficult, it's a very difficult technical problem. So that's why I think clinicians still have this advantage of, we don't just find the fork, right? We actually look at a person and we see what is wrong with this picture. And I think the nuance between finding the fork and finding what's wrong with the picture is a really important one. It differentiates something that's good at a very specific task versus someone who's a good clinician. And for me as a clinician, I would love help with that task. I don't like doing that task, or I don't like spending the amount of time I currently spend doing it. If someone could feed me that information and I could rely on it, I could trust it, and then I could use that, that makes me a better clinician, a more efficient clinician, all of the things that we want to be as physicians. So I think instead of threatening people, it actually empowers them. It presents opportunities. So I show you the picture here of one of my patients, just a portion of their back. This guy's got probably 400 moles, and they're all different, right? You look at this and you say, what the heck am I going to do? Context also matters in sort of timing, right? What a mole does in the context of time, how is it changing over the course of years? How is this individual's mole sort of behaving? Are there new ones? Is this growing more rapidly than the other ones? That is as important as what it looks like. And so what we've been working on is trying to tackle that problem of the single lesion versus the more global picture. And we're kind of there. If I had more time, I'd show you data. But what we are able to do is take a picture of someone's back, and then take a picture of their back later in time. And we're able to actually match lesions to know that this is this, and this is this, and this is this. And it doesn't have to be in the standardized environment. We can take a photo like this, and we can take it in different lighting. We can take it at a slightly different angle. So we're able to at least know over the course of time, matching what is what. And then we did something funny. We said we can't wait for time to pass and for things to develop or for things to change. What we did was we actually artificially changed them, right? We maybe colored in, a little edge where we actually stuck on sort of new moles that we created on Photoshop, essentially. And we were able to pick those changes up. So not to the minute amount of change that we would need to for this to be clinically relevant, but enough where I think that is actually a direction that can be very powerful. That's another task, right? That's another task that we as clinicians don't do as well as we could. And if we could do it better, that would really, again, it would help patient care. It would help us detect melanomas. It would do all the things that we talked about. All right. So really what I think about the future of our specialty being is that of an augmented clinician, right? I want to be able to be a doctor and do what physicians do best. And that's that human element. That's that human element and also putting things together where we say, what is wrong with the picture? What is wrong with this picture? And I don't think that will change anytime soon. And if it's 2050, I might be retired by then, maybe. So I think we'll be okay. But I think that's sort of the dichotomy. So this is a patient's legs, someone with psoriasis. So this is someone right now, what our standard of care is, we bring them in, we make a diagnosis, we see them, we do a treatment, we say, hey, come back in 3 to 6 months. They come back in 3 to 6 months, we change the treatment, we do this over and over until they're happy and we're happy. That's not really the best way to do it, right? So one, we make a diagnosis, and why are we waiting 3 to 6 months? Why can't the patient be taking a picture or having some device that spins around their legs once a month, and it captures for me the information that I would glean from them coming in? And then I get an alert that says, hey, it's 45% better. Their PASI score, the score that we use, is 29% down, or it's 50% higher. Then we can intervene when we need to. That's what precision health is about, right? What we're doing right now is not precision health. We're doing physician-centered, system-centered care. I think that what this stuff allows us to do is it allows us to be more patient-centric. And if we think about it that way, I think that's the direction that I'm really excited about, is not how is this going to take over our jobs, but how is this going to make us better at what we do and empower us to be better at what we do. All right. So I'll just close by showing you a picture of this patient. I saw this patient on April 17, 2017. So he came in, and he's one of my patients who has had a lot of sun damage over the course of time, a lot of sun growing up. I think he played beach volleyball. And he had this large freckle-looking thing on the shoulder. And so for something like this, it doesn't look quite right. It doesn't look like it should be there. But at the same time, might be fine. It might be just one of these freckles. So I use my dermatoscope thing, and I look for all the features that we're taught to look for early melanomas. I don't see any of those things. None of those exist. So I say, okay, in a situation like this, we can monitor with a photograph, we can do a biopsy. And I said, hey, you know what? We've been working with this thing. And in clinic, I'll play around with this, not because I'm using it for clinical care, but because I want to see what it does well and what it doesn't do well. So I started taking pictures, different angles, different lightings. And usually when I do that, it gives me very unstable reads. It's all over the map, all over the place. This wasn't. So this actually gave me a very stable read regardless of the different ways I took the picture. And it was pretty adamant that this was a melanoma. So I said, okay. Biopsied it, talked to my pathology colleague. We took a look at it together. And she said, hey, this is showing some early features of melanoma, a kind called lentigo maligna. And that's what she called it. And that was the diagnosis. It was an early melanoma. And so because of that sort of pushing me to make that decision, we were able to essentially cure this with a surgery, and this is not going to cause any harm to his health. So if we had left it for maybe 6 or 12 months that I'd wanted to monitor it, maybe it would have become invasive. Maybe it would have impacted his health. So I show you this because in my mind, this is the first example of what we did and what we built and all the stuff that we had worked on making a clinical impact. And I'll remember that date in my mind because I hope that this is just one of many patients who ultimately benefit from this. I think we can sort of achieve the promise of how do we get better with technology, but I don't think it'll be quite what people envision, quite what the media envisions. I think we have to sort of define that for ourselves, and I think clinicians have to be the ones saying, how do we actually use this? How do we make this better? How do we have this help us? And so I really look forward to the discussions and the questions, and really thank you for your time and attention, and would be delighted to hear from any of you if you wanted to talk after or email me. This is my favorite dermatology cartoon by far. It's the suspicious mole on the shoulder. Yeah. Okay. All right. Thank you very much, everybody.